Okay, so this will be a continuation to the MCQ session last time, and we are going to start with the first one. Okay. A colleague cardiologist enlisted your advice about a 60-year-old gentleman who is diabetic, hypertensive, has angina after walking 500 meters. His echo is normal, and his SPECT showed large and multiple perfusion defects with stress-induced RV uptake. Sorry. So he is inquiring about allocating this patient to medical therapy without the recourse to invasive therapy, citing Ischemia Triad. Your advice will be, he can be assigned to medical therapy. If ischemia is too severe to be assigned to medical therapy alone or only, cardiac CT should rule out left main disease before decision. The discrepancy between symptoms and SPECT has to be resolved first. What's the meaning of this? Yani this patient is an old gentleman, he's middle-aged actually, hypertensive, diabetic, and his angina. What do you think about his angina? Yani having chest pain on walking 500 meters. That's not something like moderate to severe. It's kind of mild, moderate, not severe sort of angina. Because the angina on minimal effort or at rest is considered severe, but this is not. Large multiple perfusion defect with stress-induced RV uptake. So that's really a big deal, ischemia. So are we going to assign him to medical therapy without any further reservation, or his angina or his ischemia is too severe and serious to be allocated to medical therapy alone or therapy, or you think there is a discrepancy between his symptoms, which are not so severe, against the SPECT, which is showing severe ischemia. So, and this has to be sorted out. So what do you think is the right answer here?
Think B. D.
B? D. You mean the discrepancy between symptom and SPECT has to be resolved first?
Think so.
But how can we resolve it? By the way, there is no discrepancy. I'll tell you something, by the way. Most of the ischemia is silent. And there is big deal of discrepancy between the clinical expression of ischemia, which is called subjective ischemia. So you might find patient extremely symptomatic and there is no big deal in the non-invasive testing and vice versa. So this is actually it's so common. So it's not a discrepancy that you have to sort out. So think of another option.
To rule out left main disease.
I think induce an RV uptake induces poor prognosis, so we have to exclude the left main.
ما سامعين ولا انتوا سامعين؟ انا ما سامعه.
لا ما سامعين دكتور حاتم، في مشكلة؟
ما في
انتوا عارفين بالمناسبه انا كنت سويتش اوف وبتكلم
اوكي.
كثير عن السينيور ترايل لما تعبت. كويس انه نبهتوني.
سوري.
ثانك يو سو ماتش. طيب
حنعيد تاني.
انا ثاني ما في مشكله. قلنا C is the right answer and it has been
Yes,
chosen
yes.
by
Yeah.
yes, but not because of RVF. I tell you something. High
الصوت ما واضح يا دكتور حاتم، صوت في مشكلة.
by sex and non-invasive.
الصوت ما واضح.
الصوت
الصوت ما
interrupted.
ما واضح؟ طيب.
interrupted.
طيب. Let me check this way.
طيب كيف الآن الصوت أحسن؟
ممتاز.
أيوة أحسن بكثير.
كده أحسن.
أيوة.
طيب تمام جدا. Okay. So the right answer is C. لكن that will bring us to the discussion of ischemia triad, because in ischemia triad patients have been chosen according to severe, moderate and severe ischemia on non-invasive testing. And by severe ischemia, they mean everything, including transient ischemic dilatation, RV uptake, and everything like that. So they were, So they have chosen these patients of high risk ischemia on SPECT and on echo and stuff like that. But before they randomize them into invasive versus medical therapy, they have to do CT to rule out left main. So they have to rule out left main. After they rule out left main by cardiac CT, then they assign them to either medical therapy versus invasive therapy, and there were no difference in the hard outcome between the two groups, meaning medical therapy is as efficacious as invasive therapy in moderate to severe ischemia if you exclude left main. Okay?
Why is that يعني يا دكتور حاتم؟ ما هو once a patient has a transient ischemic dilatation or RV uptake, it means either cerebral vessel disease or left main. So why not we are going just for invasive? We found it is a left main or cerebral vessel disease.
مع high risk patient زي ده صح؟
طبعا you are so right. As far as our common practice is concerned, if we spot out this kind of ischemia by SPECT, we are usually going to go ahead with invasive angiogram.
Yeah.
لكن هنا question was not about what we are doing. It was about ischemia trial. It's about ischemia trial in particular. So make sure that you read the question so thoroughly, because your colleague is asking about the ischemia trial in this patient and whether this patient applies to ischemia trial given this clinical data or not. He applies to, or he fits into ischemia trial. But you are going to advise him, if he want to go by ischemia trial, he has to do cardiac CT to rule out left main before assigning this patient to medical therapy. Okay?
Okay.
Good. Okay. This will bring us to shortly discuss the high-risk features on SPECT. So what are the high-risk features on SPECT?
Transient ischemic dilatation.
Transient ischemic dilatation, like the one shown on upper left. See that one? This is TID. Okay, transient ischemic dilatation or ischemia-induced LV dilatation.
Yes.
Okay.
RV uptake.
RV uptake.
يبقى lung uptake برضو.
Just before we go ahead with the rest, in the transient ischemic dilatation, what do we mean and how we quantify it? How we quantify it?
بس بنشوفها إنه dilated during stress. الكافيتي يكون dilated لكن you don't have
Yeah, usually during stress in normal physiological condition, what are you expecting the LV cavity to behave? How to behave?
contracting more, so the
Yes.
chamber will be small more.
Exactly. Usually stress induces LV cavity minimization. Okay. Lakin if you have ischemia, you have paradoxical effect. If that ischemia is really big deal, is really serious, left main, 3 vessel disease, stuff like that, you will see transient ischemic dilatation, which is defined as an index more than 1.1. Yani, you calculate the LV volume during rest and LV volume during stress. If that ratio is more than 1.1, that defines transient ischemic dilatation due to ischemia. Okay? Now, you see here, the TID index was 1.58. Good? So this is clear transient ischemic dilatation. I just want to bring your attention to one important piece of information. You can just have transient ischemic dilatation without any other evidence of ischemia, meaning you don't have perfusion defects.
Yeah.
And that is called balanced ischemia.
Yes.
Meaning, the
all
3 vessels.
Just nose is the same in these 3 vessels.
Yes, exactly. Because the SPECT obeys the law of relativity. So if there is an area of ischemia, an area of good perfusion, they will appear heterogeneous. But if they are all ischemic equally, the perfusion scan will look normal. So there should be another evidence of ischemia like TID and RV uptake and stuff like that. Okay? So the balanced ischemia can be deceptive, can be so deceptive because no perfusion defects might show up. Okay? And that's why in stress test, you have to be holistically approaching, meaning you have to start collecting data from the patient's arrival. The clinical data, the ECG data, the imaging data, and all of that. And you combine all of that to reach a final verdict. So it's not about imaging standing alone, ECG standing alone, or clinical data standing alone. It's a fusion of all this data for final analysis. Okay, now what is RV uptake? Now look at the image on the left and on the right. Both are showing, if you focus enough on RV uptake, right? There is RV uptake. Do you agree?
Yes.
So what's the difference between the two?
Beside the color?
And if you allow me to zoom in, this is an RV uptake. And this one here is, look at the stress. You see with adenosine, you see traces of RV uptake. If you look at the upper row, you see the RV uptake is more appearing during stress than rest. When you look here, what do you see? They are almost equally appearing in stress and rest.
Yes.
They are equally appearing. And another important feature, which is the D-shaped LV. You see the septum is shifted leftward.
Yeah.
What's the meaning of this? So there is RV uptake here, and there is RV uptake here, but for different reasons. Can you tell me what they are?
I think on the left, due to RV failure or RV dilatation.
Okay.
The problem in the RV itself.
And
volume,
on the right?
Volume overload.
On the right, the problem in the myocardium in the LV due to myocardial infarction because the reduced uptake. Yes.
Exactly. So RV uptake does not always mean ischemia. It might just mean RVH and pulmonary hypertension.
Mhm.
اوكي طيب هو اصلا لو نحن فكرنا في الامر من بدايته يعني لما انت you do spec testing, the LV will take the radio tracer. The RV is not supposed to show in the image. Why? هل لانه is not taking the radio tracer؟ ما فيه myocardium وفيه perfusion. Why it's not seen? Why it's dimmed out by the LV?
On my theory, because it is should be rapid uptake by the radio tracer to be imaged. But when there is myocardial ischemia, it will be delayed till the radio tracer be uptake by the RV.
Mm-hmm. Okay, so it's about, you mean the rate of uptake?
Yes.
Mm-hmm. طيب هي المشكلة برضو داخلة في حاجة أهم من ذلك، هي إنه the LV muscularly is stronger than the RV and more well perfused than the RV. So it takes the radio tracer and the RV takes the radio tracer too. But in respect, by the law of relativity, the stronger wins. So the LV will shine through and the RV will be dimmed away. It's a law of relativity. This is called volume averaging. It's a pixel. The brightest pixel will dominate and will dim the rest of the pixels. That's why when the LV is shining, the RV will shy away. So when the LV gets weaker, the RV starts to appear. So what makes LV weaker is ischemia. So when the LV is suffering severe ischemia, radio tracer uptake will go low and the RV will start to appear. So the RV uptake is a sign of ischemia. لكن لازم نفهم إنه why it is a sign of ischemia. It's because of the reason I have mentioned. Okay. When you have RV uptake like the one on the left, which is showing in stress and rest with a D-shaped LV, that is not ischemia. This is RV hypertrophy with pulmonary hypertension. The ischemia RV uptake will show in the stress images more pronounced than in the rest images. Okay? So, do we understand this?
Yes.
Great. Great. And my sound is still clear?
Yes.
Good. Second, a 58-year-old female diabetic hypertensive referred for SPECT due to atypical chest pain. The patient could not exercise due to knee osteoarthritis, so adenosine is elected instead. After adenosine injection, the ECG is shown below, associated with no chest pain. SPECT images are given also. Right. So let's see, the ECG is here and the SPECT images are here. So can anybody describe the ECG and the SPECT?
Okay.
Okay, I will take the ECG. There
Okay.
is ST segment, down sloping of ST segment, depression.
Very good.
Start in V4, V5, and V6. Starting from V3, sorry.
Okay.
Even.
Great.
V2, V3, V4, and V5, and V6. There is a slight ST segment elevation in AVR.
Okay. Great. Aha. That is exactly what the ECG is about. So what's about the SPECT images on the right?
Okay. We can't see there is you can't see any TID.
Okay.
There is a fixed defect on the septal part during rest and exercise, during adenosine and during rest, I think. Otherwise, there is no defect.
Okay, so I accept all except one small part which is a common mistake actually. You know, the septal defect you mentioned, is it normal or abnormal to have this defect?
Not normal.
It is normal. Why it's normal?
It is the part with septum between the septum and the RV, so it can be any
exactly. This is
smaller.
What part of the septum is this one?
Interventricular septum.
Which part of the ventricular septum?
Mid septum. ولا ما فهمت السؤال. Mid
inferior septum.
No.
هو لكن ما
لاحظوا معاي إذا هنا نحن usually this is called the short axis view, and the second one is the vertical long axis, and the last one is horizontal long axis.
Yes.
Right. If you look at the vertical long axis, sorry, the short axis, it's given from, it's cutting from the apex to the base, from the apex to the base of the heart. So that's why you see the initial donut is small without the cavity, and the cavity gets larger as you go to the base of the heart.
Yes.
So that's the geometry of the LV. Now, what are you gonna hit at the base of the heart? The fibrous septum, the basal fibrous septum, which is not perfused. That's why you see that defect when you are going basally. Okay, so this part,
it's normal.
It's normal. This part here, this one, and you see it in stress and rest. It's normal due to the fibrous basal septum. Okay, so don't interpret it as a fixed defect. Good. So all in all, we have normal perfusion scan, but we have significantly abnormal ECG in a patient with atypical chest pain. So what's your conclusive analysis about the test? The test is negative. ECG is positive, but the images provide overriding evidence of no ischemia. Adenosine in
Maybe LV straining.
Sorry? Adenosine-induced ST depression is not specific of ischemia. The test may indicate high-risk ischemia. So, what do you think the right answer is? Is this test negative?
It's normal.
It's normal. Okay. طبعا انا اذكركم انه نحن قلنا انه بالنسبه لكل الاستريس تيست you have to be smart in analysis. You don't have to be deviated by a single feature, positive or negative. It's a matter of integrative analysis. Okay. This integrative analysis should include clinical data, ECG data, imaging data, and all of that. يعني مثلا أنا كمثال بسيط، إذا أخذت high risk patient عملت له spec طلع negative, will you buy it? No. Exactly. If I have very low risk patient عملت له spec طلع positive, will you buy it? No. ليه؟ لأنه it's integrative analysis of clinical data, ECG data, imaging data. It's not just the images what is showing. الآن I have an ECG which strongly suggests ischemia, but I have normal perfusion scan. It might be balanced ischemia. صح؟
Yes.
ممكن. لا طيب في حاجة تانية. البيشنت دي أنا maybe I forgot to tell you that this ECG was not the baseline. يعني البيشنت لما جات her ECG was normal. After adenosine, her ECG became like this. So ST segment depression developed after adenosine injection. Does that mean anything to you? Is it specific or non-specific? Like here, they say adenosine induces depression is not a specific of ischemia. You
No.
agree with that?
No.
Or do you think the test may indicate high-risk ischemia despite the negative perfusion map?
What about B?
I think D, Dr. Hatim.
You think it's D,
because
right?
the ECG. Yes,
Because
because
of
we cannot ignore this ECG changes. And it is significant ECG changes. Yes.
Yes.
Although the
Yes.
patient is symptomatic, like, I will not take it lightly.
Exactly. Exactly. And there is one thing that, you know, usually in the nuclear CBNC certification board of cardiac certification board of nuclear cardiology, they love to ask about this question of a patient developing ECG changes with adenosine, but the imaging protocol is done and it's negative. Okay? Because they want you to they want you to think of the test as integrative analysis and to think in particular of the so-called coronary steal phenomenon. Coronary steal phenomenon. إذا البيشنت حصل له ST depression with adenosine, that is a very high risk feature. Very high risk feature with or without chest pain. لأنها indicates coronary steal. How is that? If you look here, the one on the left, we have blood flow going into the coronary artery into two branches, normal and abnormal atheromatous plaque. So limiting the perfusion on one side. So we have limited perfusion on one side and we have normal perfusion on the other side. What does that mean? Look here. If you look down here, you look down, just a moment. So I just want to operate my pen. Okay. Look at this part. Compare it with this part and tell me what you see.
On the right, dilated more than the left.
Exactly. What is this dilated? The microcirculation of a diseased artery is usually dilated under rest condition to compensate for the obstruction upstairs, right? That's normal. Now, if we give adenosine, look here, and if we give adenosine, what happens?
It will dilate.
Adenosine. It's gonna dilate both. Yes. But the dilatation on the normal will be more than the dilatation on the left because the on the disease segment, because the disease microcirculation is already dilated. So it doesn't dilate as much. Adenosine dilates the normal microcirculation by 5 times. But it doesn't do the same in the microcirculation of a diseased artery. Therefore, the microcirculation here will remain low. The microcirculation here will become hyperemic. And what happens? The pressure here will fall. The pressure here will remain high. What does that mean? If the pressure here remains high, a collateral might take the blood away because the collateral works across a pressure gradient. The pressure on this side is bigger than the pressure on that side, so the blood flows in the reverse direction from a disease segment to a normally perfused segment, making ischemia worse. Making ischemia worse. This is coronary steal phenomenon. So when you give adenosine to a patient with significant stenosis and collaterals, that might reverse the direction of collateral flow from the disease segment to the normally perfused segments, leading to worsening of the ischemia in the disease segment. And that's why the patient might develop evidence of ischemia in ECG, like our patient here. So having ECG changes with adenosine is serious as a heart attack. Okay? You get the point here?
Yes.
Good. So can we move on?
Yeah.
Okay. Now we have a 62-year-old lady with hypertension, chronic kidney disease, BMI 30. Refer to you for suspicion of HFpEF. On examination, ankle edema, S4, bibasal crackles, ECG normal sinus rhythm. Echo showed dilated atrium, LVH at 1.3 centimeter of basal septum, EF is 65, grade 1 diastolic dysfunction. The best next step is HFpEF is ruled out according to the echo data. Request PMB and or stress diastolic test. Request strain echo. Do invasive angiogram.
B. Request BMB and stress diastolic test.
Okay. Good. Any different opinion?
And despite the negative BMB is not exclude the presence of heart failure.
Okay.
We have 1/3 of the patient, they have normal BMB and they are diagnosed as having hip beef.
That will probably bring us to the definitional, the definition of HFpEF itself. So HFpEF is defined as having symptoms and or sign of heart failure. That is number one. So you have to have clinical data of heart failure. Number two, you have to have an ejection fraction more than
50. More than 50. 50.
Good. And to have an evidence of diastolic dysfunction which is matching the symptoms, yani high-grade diastolic dysfunction, and evidence of diastolic dysfunction affecting the heart, like LVH, like left atrial dilatation, and these kind of stuff. Okay? If you fail to demonstrate diastolic dysfunction by echo, that's not the end of the story. If you also have elevated BNP or a positive stress diastolic test. So now let's go back into the definition. So the definition is symptoms and or sign of heart failure, ejection fraction more than 50, evidence of diastolic dysfunction by echo, or high PMP, or positive stress diastolic test. Now طبعا هم عقدوها شوية، أنا شايف my own impression، بقى في scoring system I'm gonna show you in a bit. في scoring system للdiagnosis. لكن that's remain the cornerstone because this is definitional part of the HFpEF itself. Okay. فنحن الآن this patient عندها symptoms and or sign of heart failure. Yes. طيب. She had an ejection fraction more than 50. Yes. Does she have diastolic dysfunction to explain these symptoms? No.
No,
because
no.
it's only grade 1. Okay. So we have to move on in the workup. High PMP and or stress diastolic test. So we're going to choose B. So the message here is don't wrap up the diagnosis of HFpEF based on echo alone. Yani if you manage to diagnose at the level of echo, well and good. If not, you still have a remaining workup to do, which is BMP and diastolic stress test. Okay? Strain might be of value, but it's not yet clinically applicable, especially in HFpEF. يمكن in HFrEF, yes, we are using and it's of clinical value and it has meaningful clinical messages, but for HFpEF, not yet. Okay, so what we are going to do is BMP or stress diastolic test. With stress diastolic test, like in this patient, if I take you here, this is the scores I have been talking about. The HFpEF scores based on يعني مثلا هنا these are clinical variables. وهنا, which is more important, and it is PEF1, F2. Okay, so the initial workup is the pre-test assessment that depends on the clinical data. Okay, and the diagnostic workup initially includes comprehensive echo and natriuretic peptide. Advanced workup is diastolic stress testing, which can be echo or can be invasive hemodynamic measurement. And there is etiological workup, which is basically geared towards revealing the etiology and the comorbidities and treating from the roots. Okay, but this is generally speaking is the workup for HFpEF. Okay, and here is if you have signs and symptoms of heart failure and you have an ejection fraction more than 50, if you have LV diastolic dysfunction, meaning E over E prime more than 15, that is it, right? That is HFpEF. Or if you can have more than 15 with exercise is also important feature. Or if you have pulmonary capillary wedge during invasive hemodynamic during exercise more than 15, these are all diastolic stress testing. Okay, or pro-PMP more than and stuff like that. So يعني more or less it's becoming more complex, right? يعني it's not ending at echo. There is invasive hemodynamics by exercise. There is exercise echo, and there is stuff like that, and the PMP. That's the message. So the take-home message here is that HFpEF in terms of diagnostication is as complex as in terms of treatment, and echo is not the final story. If echo is positive, well and good. If it's not, you have to go for invasive exercise hemodynamics or exercise echo or request PMP. Okay? Tom, you might ask me, how can we do invasive exercise hemodynamics? Can you do that? Have you ever thought of it? Invasive exercise hemodynamics. I'm waiting for your answer.
ممكن يكون فارماكولوجيك دكتور حاتم. فارماكولوجيك ستريس.
No, it's physical exercise.
إلا ergometry.
Exactly. It is. It is bicycle ergometer. So you exercise the patient at his lower limbs. The rest of his body is steady. So you can be okay. And we also, by the way, if you consider echo, the treadmill is a problem in exercise echo because you exercise the patient on a treadmill, then you bring him to bed, right? During this time of achieving maximum heart load, workload, you bring him to the bed, and that might take time, and everything we have gained might be lost. That's why even in echo, people like to have bicycle ergometer. So the patient is exercised while you are acquiring. In invasive hemodynamics, it's the patient is exercising by ergometer, bike, as you are measuring the pulmonary capillary wedge. Okay, good. So back to our patient. The above mentioned patient is shown to have pro-PMP of 600 and E over E prime after 3 minutes of treadmill exercise is 25 compared to the baseline of 8. So what do you think now? Is it HFpEF without any reasonable doubt?
Yes.
Yes. Yes.
Yes.
Yes.
Yes.
Khalas. Patient has symptom signs of heart failure. Her ejection fraction is more than 50, elevated PMP, and positive stress diastolic test. So it's HFpEF. Now, which of the following medication is likely to improve mortality? Loop diuretics, MRA, beta blocker, ACE inhibitor, SGLT2 inhibitor.
SGLT.
طبعا يعني لحد فترة قريبة بنكتب في الأوبشن في هنا none of the above, and the right answer was none of the above. But now we have at last we have a hope in SGLT2 inhibitor might be a mortality benefit in these patients, or might possess a mortality benefit in these patients, according to Emperor Preserve trial, okay, which was discussed in the European Cardiology of European Society of Cardiology 1.5 months ago, okay, and now it's in the guidelines already, SGLT2 inhibitors. So according to Emperor Preserve trial. وده طبعا غير في اللاندسكيب of heart failure across its both domain, REF and BEF. But before we go to that, let's take this question. The patient is started on empagliflozin along with her regular medication. Empagliflozin is the SGLT2 inhibitor. Which of the following is true about empagliflozin in this patient? It is likely to have less effect than if her ejection fraction is 52. She is likely to have more benefit than a similar male patient. Empagliflozin is going to significantly increase genitourinary infection. Empagliflozin is going to lead to a significant deterioration of her renal function. So, which one?
C. C.
C. Mm-hmm. Okay. Any other opinions?
B. maybe B
Because
because
of
إنه الهيب it's more common in elder female.
osmotic glycosuria, the female is likely to develop infection.
Exactly. Yeah. I think this MCQ is a bit tough, but let's think of it together. You said people with those going to increase genitourinary infection, and that is right. But the only objection here is that this increase is not going to
والصوت
بعيد يا
مش
دكتور حاتم.
الصوت ما واضح. معلش.
شكل الصوت قطع مرة واحدة.
It's going to lead to a significant deterioration of parental function? No. Actually, according to these trials,
حاتم.
proposed as a reproductive agent as well. That's why.
Excuse me, Saya.
دكتور حاتم معلش we can't hear you.
دايما we miss the very important
Okay.
دكتور حاتم شكله في مشكلة في الفويس. شكله في مشكلة في we can't hear you well.
ممكن زول يرسل له على الشات.
واحدة بس.
دكتور حاتم. ايوه. لسه دكتور حاتم في مشكلة شكله في السماعة ولا كده. لسه الصوت يا دكتور حاتم. Still the voice is not okay. We lost your voice, Dr. Hatim.
Hello? I have a real problem with the sound today. I don't know why. Now my sound
now
is clear?
okay. So clear now.
Okay.
Yes, now clear.
I'm going to take you to this one. This is the subgroup analysis of emperor preserved. Look at the sex, male and female, and look at the benefit. Who is going to benefit more, male or female?
Female.
Female. That's good.
Yes.
Now look at the, what else? Look at the ejection fraction. Less than 30, less than 30 with PMP, more than 30. Who is going to benefit more?
Less than 30 with BMB, more than median.
Exactly.
In the middle, yeah.
طبعا you might ask why less than 30 is in this trial. هم مشكلتهم في emperor preserved. They have included patient of mid-range and normal range. يعني they were not purely HFpEF patients. ودي واحدة من shortcomings of the trial itself. ولاحظوا حاجة مهمة جدا إنه الإفكت بتاع drug empagliflozin is attenuated as we go north with the ejection fraction. يعني كل ما الإيجكشن fraction ماشي في اتجاه ال 60 plus كل ما الإفكت بتاع empagliflozin is less. And what does that mean? That means we are back to square one. We still don't have an efficacious drug in the typical HFpEF patient, because HFpEF patient اللي احنا بنشوفهم the rejection fraction is 60 and above. Is 60 and above. لكن they are extremely shortness of breath, and they have grade 3 and 4 diastolic dysfunction. They have LVH. They have dilated left atrium. انت الان in Emperor Preserve you are telling me that the more we go high in the ejection fraction, the lesser the effect of empagliflozin. Empagliflozin was found to be more efficacious in mid-range EF. وبالتالي هي مشكلة إلى الآن، ولكن out of desperation and because we have nothing else بقى مهم وبقى mortality drug وبقى والآن خلاص prescribed everywhere وهكذا. طيب بس now the landscape of heart failure along its two domains, HFrEF and HFpEF. And I made it easier for you. BSAM for HFrEF and coercion for HFpEF. BSAM, beta blocker, SGLT2 inhibitor, ARNI or ACE or APS. Of course, ARNI before the rest. And MRA. Okay, these are all class 1 indication. Now, when we come to HFpEF, treatment of comorbidities on their own merits, exercise, relief of congestion, SGLT2 inhibitor, and being on the lookout for further progress in the diagnostic and therapeutics of HFpEF, coercion. So SGLT2 now is occupying a prestigious place in both HFrEF and HFpEF. Okay. صوتي واضح يا اخوانا؟
Yes, clear.
بس شكلكم زعلانين من الموضوع ده صح؟
لا والله.
بس اكسكيوز مي دكتور حاتم، بس ممكن ترجع للستيمز بتاعت السؤال ذاته؟
بس المشكلة الليلة الشبكة we missed a lot of talk يعني.
طيب ده هو السؤال.
طيب
السؤال A and B both are right by the way، لأنه she is likely to have more benefit than a similar male patient. Yes, لأنه empagliflozin is more effective in female than in male. It's more effective in lower ejection fraction than higher ejection fraction. يعني البيشنت دي عندها ejection fraction of 65. So she is likely to reap less benefit than if her ejection fraction is 52%.
Yes.
لا يعني هسه the right answer is B or C.
لا, the right answer is
A and
really,
B. I get
A or B
together. طبعا
B.
السؤال غلط معناته تركيبته لأنه we have to have one answer only which is right, but in this one it's A and B are right, C and D are wrong.
Yes, okay.
Okay, good.
Sorry, sir.
Yes.
There is a general agree about complication of SGL2, urinary genitourinary tract infection. So see how C also is wrong.
C. It is so undoubted that empagliflozin and SGLT as a class, they increase the risk of genitourinary infection. Okay? So, we are not disputing that empagliflozin is going to increase the risk of genitourinary infection. The only dispute here is that increase going to be significant or not significant. And according to the emperor, because that's the only evidence we so far have, no significant difference between the two. There is numerical increase, but it's not statistically significant between the two groups. Okay, but that's that. The real life data might change our mind about these medication a lot. لأنه في نهاية الأمر clinical trials are conducted in idealistic circumstances, and there is a great conflict of interest because the manufacturer are sponsoring the trial. فممكن نلاحظ إنه الأمور اختلفت. هل عندنا تجارب زي دي؟ Yes. العالم فيه تجارب كثيرة عن drugs were marketed as one of a kind and في نهاية الأمر recalled from the market because of serious effects. Yeah. لكن as far as emperor, preserved, pooled, and reduced are concerned, the increase in genitourinary infection is numerical and not achieving statistical significance between the two.
Can we add just except for the question and then we have the D as an answer?
Except, yeah. If except, yes, D might be an answer. I agree with you. Yeah, but still, it will be skeptical to choose C because C is significant increase. وطبعا, by the way, if there is significant increase in genitourinary infection, they will never market this drug as +1 indication. لأنه genitourinary infection, if it's markedly increased, that will just overwhelmingly sabotage the other bright effects of this drug. Once I have this increase in genitourinary infection in these patients who are elderly, so it's not going to be cost effective. I'm going to give patient for 1 month and treat them in the hospital for a few weeks. So it wouldn't be a cost-effective drug and it would not be marketed as +1 indication. So as far as the trials are concerned, it's still no significant increase in genitourinary infection. There is a marginal numerical increase, but it's not significant. ولكن, let's wait and see.
Excuse me, Dr. Hatim.
Hmm?
Regarding the
Yeah, go ahead.
A and B are right. I agree with you in B. But regarding A, if we return back to you, what you say, according to the trial, the efficacy of the medication, it's more with the mid-range and with reduced ejection fraction. If we consider more than 50 is preserved, so the action will be in the more than 50. If it is the 52 or 60 something, so it is with preserved ejection fraction. So the action is similar. It's not less effective. So I go with that. The best answer is B, and what I think is wrong.
Yes,
because they are the same. They are hip beef, and the action in the hip beef is similar, not less.
هم طبعا in HFrEF, I mean in Emperor reduced, they have chosen perfectly HFrEF patients. But when they come to HFrEF, Emperor preserved, they have chosen patient of ejection fraction more than 35. So 35 is included, 40 is included, 50 is included, 60 is included, above 60 is included. They have noticed that the effect of empagliflozin is attenuated as we go high in the ejection fraction, meaning 40 is more efficacious. The drug is more efficacious in 40% ejection fraction than 50%, which is more effective than 60%, which is more effective than 70%. So there is a trend that the drug loses effectiveness as we go north in the ejection fraction. لكن ما قالوا إنه it will stop to have any effect in ejection fraction of 60%. No, it still have an effect. لكن less than 50%, which is less than 40%. اوكي. ولكن طبعا لانه نحن بنتكلم عن a situation, clinical situation of desperation, which is HFpEF. It has been so long time since we last have any medicine that can help us in mortality improvement in this patient. So this is a glimmer of hope. ولكن أنا حاسس إنه a trial itself is designed in a way that intended forcibly to have this positive result. ولذلك أنا I'm not feeling so happy with Emperor Preserved in particular. ولكن it has been discussed thoroughly and people are agreeing, authorities are recommending it as class 1 and stuff like that. Okay. Okay. Did I make myself clear here?
Yeah. Thank you.
Right. Now we have this. The following echo is of a 33-year-old patient who has experienced unexplained syncope twice. Otherwise, the patient has good functional capacity. The best course of action at this stage is beta blocker, septal myomectomy, secondary prevention of VTAC, cardiac MRI.
Secondary
what
prevention
do you
for the
echo? What does the echo
shows
show?
hypertrophic cardiomyopathy, asymmetrical septal dilatation, أو أقصد hypertrophy.
With yes, you are right. And there is also what?
Mitral valve.
SAM.
Systolic
anterior motion of the leaflet. You see during systole, this is a systolic phase, and the anterior leaflet flies toward the septum. So this is SAM. So we have asymmetrical septal hypertrophy and SAM. So this is Workup. So what are you gonna do here?
We're going to the patient has to he explained twice syncope, so better to have a secondary prevention for it by inserting an ICD.
Why not to start beta blocker first?
According to the risk stratification, he has syncope.
The other thing is that medication in Workup are not meant for prognosis, are meant for symptoms. Yani if the patient can symptomatic and the patient here is not symptomatic, we might give beta blocker. Okay, lakin for prevention of sudden cardiac death, ICD. And patient they are into symptoms to justify giving medication like beta blocker, but he has one very serious high risk feature, which is unexplained syncope twice, and this will qualify him for ICD right away. So why not CMR to make sure that he had fibrosis, no fibrosis? Because now CMR is indicated in the analysis of Workup and in quantification of fibrosis to see if this patient qualifies for ICD or not. So why not in this patient?
Because already have qualified.
Thank you so much. Exactly. He already qualifies. We shouldn't go for any waste of time here or waste of resources. ولكن CMR can be indicated or is indicated for special circumstances, which are, let's find out. If you look here, just a moment. In patient with Workup, do you see the slide?
Yes.
Is the slide seen to you?
Yes.
Right. In patient with Workup, a comprehensive symptomatic non-invasive sudden cardiac risk assessment at initial evaluation and every 1 to 2 years, which includes personal history of sudden cardiac death, ventricular arrhythmia, personal history of syncope, and family history, maximal LV thickness, ejection fraction, LV apical aneurysm, non-sustained VTAC. The conventional risk factor we know about. Okay. Now, for patients suspected to have Workup in whom echo is inconclusive, CMR is indicated. So it's indicated diagnostically if you have suspicion of Workup which is not sorted out by echo. Also, for patient with LVH in whom there is suspicion of alternative diagnosis, again, you are not so sure. Or for patients with Workup who are not otherwise identified as high risk for sudden cardiac death, or in whom a decision to proceed with ICD remains uncertain after clinical assessment. In this case, you do CMR to quantify the myocardial fibrosis with late gadolinium. So the indication of CMR in Workup, if the diagnosis is suspicious but not confirmed, and if the patient is to be assessed for myocardial fibrosis for ICD if clinical assessment does not show high risk features. Because if it does show high risk features, you don't have to go for CMR for further workup. You already have an indication, go for ICD. Okay? Good? Right.
Yes.
هل الكلام ده ممكن يتغير؟ نعم ممكن يتغير. يعني لاحظوا الآن CMR is indicated late in the workup for ICD indication in Workup if the patient has no conventional risk factors. الآن الناس بتتكلم عن إنه why not to be more proactive؟ لأنه CMR will tell you about the fibrosis, which is the substrate of VTAC, may be earlier than the conventional risk factors. فإذا أنت استعنت بالCMR, you will be proactive instead of being reactive. لأنه إذا انتظرت البيشنت حصل له syncope وإيش ده هنا أنت هتكون reactive. You are reacting to a serious situation. So why not to use CMR to be proactive؟ الحكاية ممكن تتغير. يعني ممكن CMR تنتقل فوق، ولكن الجايد لاينز are usually not usually actually always designed so as to encompass the ubiquity, the universality, and the cost of the technology they are recommending. يعني إذا قالوا CMR for all Workup patient، وCMR تتلاقي وين في كل المراكز بتاعت القلب؟ ما ممكن تخلي حاجة كلاس 1 indication وهي ما متوفر لها الاكسبرتيز، الكوست بتاعها هاي، it's not ubiquitous، it's not موجودة في أي مكان، ف يعني بتبقى هنا مشكلة. ولذلك هم دائما في الجايد لاينز بيقول لك تحت في ديسكليمر، إخلاء مسؤولية، إنه يا إخواننا أعملوا الحاجات دي according to your own judgment based on your experience and your expertise and the excellence of your center and stuff like that. يعني مثلا in our center we might go ahead to CMR for all Workup patients to quantify fibrosis without waiting for syncope and VTAC and stuff like that. Okay, because we have it just around the corner. The booking for CMR is just 1 week. So why should I wait for syncope? ممكن أنا I take it this way. ولكن as far as the recommendation are concerned, CMR is for further workup after the clinical assessment. Okay? So, thrombus formation has a predilection to this structure because, which is LA appendix, and you see the thrombus. And the mitral valve is seen from top. This is surgical view. Why? Why thrombus are formed specifically in the LA appendage? Because it's a vestigial structure, يعني تركيب أثري, or emptying is more dependent on atrial contraction than LA cavity. It is more rigid than LA cavity. It shows a smoke sign, which is dense, spontaneous contrast under physiological condition of blood flow.
B.
B.
B. B. Emptying is more dependent on the atrial contraction than LA cavity.
Wallah, ya akhi, thank you so much.
Yes, I agree with.
This is exactly the right answer. And if you see here, if you compare the mitral inflow, which empties the LA cavity, you see the initial flow, which is E, is big. That is bigger than the atrial contraction flow. معناته شنو الكلام ده؟ معناته it's more dependent on the initial flow. يعني if you lose the A because of atrial fibrillation, you're not gonna lose a lot of flow. Still the flow is gonna go like 80% and there will not be much stagnation. Compare this with the flow here. You see the late diastolic emptying flow of the LA appendage. Compare it to the early diastolic emptying velocity flow. Is so different. LA appendage is much more dependent on the atrial contraction than the rapid early emptying. Therefore, in atrial fibrillation, it's affected much more than the LA cavity. That's why LA appendage forms in there in particular. Okay, good. Now, a 85-year-old male, long-standing history of ischemic cardiomyopathy, which persisted after revascularization. His ejection fraction is 25% with multiple regional wall motion abnormality and severe ischemic mitral regurgitation. He also underwent ICD-CRT. He remains symptomatic despite guideline-directed medical therapy delivered as much as tolerable. What is the best course of action at this stage? Like, are you going to do transcatheter edge-to-edge repair of the mitral valve, heart transplant, LVAD, end-of-life care?
A.
Yes, A. According to the last guidelines, A.
A. Exactly.
Yes.
So you're right. Good. So you said according to the last guidelines? Yeah, and these are the guidelines. I'm not gonna go through it. The Keenan and mitral clip is in the guidelines for these patients who have prohibitive surgical risk and who failed medical therapy. Okay, for primary and for secondary mitral regurgitation, for both. And of course, this is the mitral clip system. As you see the delivery system, and you see the most important part is this one here, the arm and the gripper. So the leaflet of the mitral valve is held between the arm and the gripper, and the interventionist, when he made the right grasping, he laid down the gripper to grasp the leaflet. طبعا this procedure is 100% TE guided. 100% TE guided. يعني the echocardiologist has to be with the interventionist من البداية إلى النهاية. Okay? It's so echo dependent. لأنه you first has to guide the interventionist to the right piercing site in the septum, where this varies according to what type of MR you are dealing with. بعدها you direct the operator to the LV, and then you direct the operator to the right jet, and you assess perpendicularity. يعني الكليب ده لازم يجي صاعد من ال LV للmitral valve in a perpendicular way, ما يكون oblique. لأنه لو بقى oblique it will not be efficacious in eliminating MR, besides إنه ممكن يكون easy to embolize. فلازم ال perpendicularity, and this is basically judged by TEE. بعدين ال grasping, which is judged by TEE. بعدين ال final release of the clip system. Then you review the result, how much of MR is remaining. If still there is MR which is significant, you might go for a second, a third, and fourth clip على كيف الناس اللي بعدين بيكون بيفكروا مع بعض وهكذا. ولكنها it's completely TE guided procedure. Okay. طيب. Last two questions. A 53-year-old lady diabetic with atypical chest pain. Her echo is normal. ECG showed left bundle branch block. Which non-invasive testing is best for this patient? Treadmill exercise ECG, dobutamine echo, exercise SPECT, dobutamine SPECT, adenosine SPECT. I expect you answer it so fast. Which one?
E.
A?
E.
No, E and vitamin echo for left bundle is not the
Very
diagnostic.
good. Yeah.
No,
So this is left.
adenosine SPECT.
Adenosine SPECT, you are right. So the right answer is E, because of in left bundle, exercise ECG is uninterpretable. And in imaging, left bundle will create artifactual perfusion defects or motion abnormality. If you are using inotropic pharmacological stress or exercise. يعني dobutamine is exercise-like because it causes increased inotropy and stuff like that. So it creates the same artifactual problem. So exercise is avoided and inotropic pharmacological stressors are avoided as well. Okay. يبقى ما عندك خيار غير vasodilator SPECT. Okay. Great. Now, a 73-year-old man, long-standing history of HFrEF, admitted with decompensated heart failure. His ejection fraction 6 months ago was 25%. Repeat echo will most likely show further drop in ejection fraction, evidence of increased filling pressure, evidence of acute severe mitral regurgitation, evidence of RV strain.
C.
Why not
C.
B?
Why not B?
Symptomatic, it can be due to increased filling pressure.
So why not A? يعني هو his ejection fraction is 25
not acute MR. B chronic MR, but
yes.
B evidence of increased filling pressure.
Yes. So the right answer, I agree with all of you, is B. The right answer is B. Yes. Why B? Yeah. Why B is the right answer? لأنه أول حاجة a decompensated heart failure or decompensated episodes are not due to drop in ejection fraction. يعني patient تلاقيهم severe LV dysfunction 30 يجيك decompensated heart failure, you do echo. Are you expecting in ejection fraction bigger 15, 10? No, it's not about the ejection fraction. The ejection fraction remains the same, لكن اللي بيتغير هو diastolic pressures. الفيلينج pressures بتتغير. الفيلينج pressures هي اللي بتتغير. اوكي؟ والMR ممكن يكون له contribution في decompensation وفي بعض الأحيان ممكن يكون subacute because of chordal rupture because of the stretches ولكن غالبا الMR is chronic in this context. It's chronic يعني ما هو acute. Okay? This is the situation. So usually it is evidence of increased filling pressure. Okay. 26-year-old lady with chest pain and shortness of breath, diagnosed with large pulmonary embolism. Blood pressure is 110/70, heart rate is 110. The intensivist requested echo to decide about lytic therapy. What is the best course of action? Lytic therapy is indicated without further delay. You are going to refuse to do echo because lytic therapy is already indicated. absent McConnell sign rules out RV strain. RV strain could be seen in the same CT which diagnosed pulmonary embolism. ECG and PMP has no role in the prognosis of pulmonary embolism.
C.
C.
I'll go with C.
Exactly. And this is the right answer. And that's why نحن بنقول يا اخواننا في حاجة اسمها redundancy of testing. Liar testing or redundancy معناتها انت you already had an answer but you insist to request another test for further confirmation of the same answer which is already confirmed. That is a waste of time, waste of resources, and waste of everything. والكلام ده حقائق بتواجهنا. يعني أنا أقول لك honestly speaking, just 1 week ago they refer a patient to me لأنه الintensivist was insisting to do echo. والpatient عندها large pulmonary embolism وعندها dilated RV in the CT with leftward shift of the septum. مش كده وبس. A radiologist has also documented that إنه في reflux of contrast in the IVC and hepatic vein. What does that mean? The pressure is so high وفي TR لدرجة إنه the contrast is reflecting back into the IVC and the hepatic vein. يعني خلاص you have an evidence. Why should you go for echo? وأصروا and they twisted our arm and we did the echo and we just have replicated the same finding of CT. Okay? It was unjustified delay of time. يعني it was a crime. Is a patient mad during this time? Yet it's a real crime. CT can give important data about the RV strain. If you ask the radiologist, حتى لو radiologist sometimes, by the way, does not report it, you can go to the radiologist and ask him to look at the RV. And it's easy, by the way. It isn't difficult to assess RV strain by cardiac CT. Now, ECG is also prognostic, يعني إذا في tachycardia وكده. And PMP, if it's elevated, it might also support the diagnosis of RV strain. Okay, so these are all features of history. And that's the end of it. Thank you. Thank you so much.
شكرا لك دكتور حاتم.
شكرا جزيلا.
Excuse me, Dr. Hatim.
Yes.
Regarding.
Yes, go ahead. Regarding C.
Regarding the question about the syncopal attack in patient with the Workup. Is that a secondary prevention? Because
yes,
the patient have no any.
Yeah.
The patient has no any document. Any documentation about he have VT and he has syncope. We didn't know if this syncope is related to the presence of VT exactly or due to this outflow obstruction. And this is indication for primary prevention.
هي طبعا الحته دي ممكن تكون سيمانتيك يعني اختلاف اصطلاحي لكن نحن we agree لانه في بعض الناس بيفتكروا انه syncope is akin to a sudden cardiac arrest. Okay, is akin to cardiac arrest. It is a minimal or miniature cardiac arrest. إذا البيشنت has syncope unexplained بمعنى ما في explanation ثانية خلاف الفيتاك. ما هو عشان كده كتب unexplained syncope twice. معناتها حصلت له VTAC twice. Unexplained معناتها I have no other alternative diagnosis of syncope إلا إنه يكون VTAC. In this case, I will consider it as secondary prevention. Okay.
The outflow itself can lead to this syncope.
ممكن yes. I agree with you. لكن هي في حالة الأمور بتاعت إنه السينكوبي of the LVOT هي طبعا ال MCQs دائما ما بتديك السيناريو بشكل كامل. لكن أنت مثلا بيجيك patient إذا عنده arrhythmic syncope versus obstructive syncope البيج ديفرنس بين الاثنين هو الاكسرسايز، صح؟ يعني الاكسرسايز العادي دائما الاوبستراكتيف سينكوب بيحصل في الاكسرسايز اكثر، مع انه الاريثميك سينكوبي ممكن برضه يحصل في الاكسرسايز لما يكون شويه شنو؟ كومبيتيتيف، شويه هاي جريد اكسرسايز، لكن بيحصل عندهم مرات without any provoking factors. فانت you have to make sure what type of syncope you are dealing with, and you have to encompass in your analysis the degree of LV obstruction. وطبعا لما تعمل echo, usually the echo is done with provocative maneuver to see the obstruction at baseline and with provocation. وهل في high grade stenosis ولا لا؟ وبعد ده تحكم على السينكوبي مكانه وين في الاشياء زي دي. لكن دائما كلينيكلي انت طبعا احنا عندنا قاعده كبيره to err on the side of caution، صح؟ اذا غلطت اغلط بالحذر. to err on the side of caution. يعني اذا عندك syncope it's better to assume the worst in who than انه LVOT obstruction. I might assume انه I take this patient for ICD وبدل ما انه انا اقول لا let me analyze further and further which might take 3 and 5 months لحد ما اكمل الاناليسيس. فهي فيها برضه شنو clinical judgment، يعني ما في black and white here, it's a matter of clinical judgment. Okay.
Okay. Really, thank you so much. We can't thank you enough, Dr. Hatim. Really, والله العظيم جزاك الله خير.
يعطيكم الف عافيه يا رب، ونشوفكم المره القادمه